So this morning's sessions, we heard a lot about cutting edge research on ADTKD and cutting edge research on therapeutic advancements. But we can't learn about ADTKD if patients aren't getting diagnosed. So this afternoon, we're going to hear from three experts on how to integrate genetic testing into clinical practices. We're first going to hear from Dr. Andrew Lazar, the Chief of Nephrology at University Hospital's Ahuja Medical Center and Clinical Trials Director at University Hospital's Cleveland Medical Center, who will present a case study and share his clinical insights on when and how to refer patients for genetic testing. Next, we'll hear from Maggie Westemeyer, a genetic counselor and Director of Clinical Genetic Services in Organ Health at Natera, who will discuss the support provided to nephrologists before, during, and after referring a patient for genetic testing. And then finally, we'll hear from Dr. Madhavilatha Vuppali, a nephrologist affiliated with Memorial Hermann Health System and Houston Medical Hospital, who will describe how she has seamlessly integrated genetic testing into a 15-minute clinical visit. And you should each feel free to share a little bit about yourselves, your background, if you like. And we'll hold questions till the end of the entire panel presentations. All right, let me turn it over to you, Andrew.
Okay, I really appreciate the opportunity to be here. You can hear me okay, Sharon?
Yes.
Great, great, great. Thank you so much for having me. I am I'm the head of clinical trials, University Hospitals of Cleveland, focusing mostly lupus, IgA nephropathy, APOL1. But I'm really a city-dwelling nephrologist. I just see people every week. And I really wanted to share my journey of going through that revelation of someone who didn't really appreciate the impact of genetic testing to going through this journey and now recognizing that, wow, in 2026, when I see people, 50 to 100 people outpatient every week, that we have to fight to make a diagnosis. That when we leave people undiagnosed, we have trials and we have drugs that are coming, and we have to get people in trials, and we must make a diagnosis for the patient's sake, and they are counting on it. So I just wanted to share, this is the kind of patient who I would see a number of times per week. Mr. X, 45-year-old man. Today, between Google and ChatGPT, people come to the office and they already know what they have, right? This gentleman comes, he has been told maybe he does have ADPKD, he's got bilateral kidney cysts. There is a significant family history of PKD. Many of his family members have CKD and they have kidney cysts. Yes, the GFR's dropping, but the cysts are stable. The kidney size by ultrasound is only 10.5 centimeters bilaterally. So you look at this kind of case, so many of the cases that I see every day, all week long, I can't say with certainty what someone has. And yet, I think that we have to fight to understand what people have if we want to tell people what your prognosis is. Do we have treatment options? So why would I think about genetic testing here? What does Mr. X suffer with? Kidneys are not particularly large. That doesn't mean he doesn't have PKD. We order a CT. We're waiting on total kidney volume. Now, if this is PKD with a somewhat atypical course, I'd like to know what this gene is, right? Now, if they have a truncating PKD1, that is worse. A non-truncating PKD1, maybe ever so slightly better. PKD2, better yet. But there are a number of other genes now, IFT140 and others, for which I'd like to know what that gene is. So now this patient, this could be an atypical PKD. It could be a different disease. This is now something that I would really still call CKD unknown etiology. This is really this is a class of disease now in nephrology, CKDU, CKD unknown etiology. And this is what I think about every single day. Why do people come to see me? They want to know, what do I have? Why? What will happen to me? what are the treatment options? And I want all of my colleagues to really think through when we see a patient, this is their anxiety. And then they also want to know, will this affect children? Will this affect nieces, nephews, siblings? So we have a lot of data out here published that, and this just happens to be one in the German CKD study where they looked at over 5,000 patients just who had GFRs of 30 to 60 or quote unquote overt proteinuria. That's all they looked at, and they had a group of people who went through every single chart to say, do we know what this patient has? And they felt when all was said and done that 20% or more were really CKD unknown. They didn't really know. Now, I would argue that we way overdiagnose diabetics as having nephropathy related to that diabetes. Should someone have hypertension, this is probably not the cause for their CKD. You have to look further. So when I started seeing these data and I looked at my clinic, I really felt that it's probably upwards of 40% of my patients that I don't really know. And that's not good enough today. Now, you start looking at what's the impact of doing broad genetic testing for this group of patients who have CKD unknown, and trials like this, where they looked at a group of over 440 patients, had a diagnostic rate of 22%. Now, there's something about this 20% number when you look at all sorts of recent trials of doing broad genetic testing for those who may have a family history, they have unknown etiology. All of these trials are showing somewhere in this 20 to 22% range. There is no other test that I order to rule out disease X, Y, or Z. Doing an echocardiogram, doing an SPEP, UPEP, looking at different antibodies, that I have a diagnostic rate of 22% that changes what I do for that patient. So we've got to think about the integration of genetic testing for many, or even most patients who we see in CKD clinic. This is yet another one out of Columbia. They looked in their CKD clinic and said, if you meet just one of these three criteria, you have a family history of CKD, a suspicion of genetic CKD, which they didn't define further, or you have CKD unknown etiology, I'm going to do a broad genetic test. And they found 92 patients who they did a broad genetic test. And for those 92, 22 of 92, 24%, they found an answer for why that patient had CKD. They had X-linked as well as autosomal output, dent disease, HNF1B. Here is one of the ADTKDs, UMOD, TRPC6 FSGS. That's something I want to know. You know, a TRPC6 patient may respond very well to calcineurin inhibitors. Little syndrome. Do I want to miss a Fabry's when I have Fabrazyme so I can treat this patient? So these are not obscure diseases. These are diseases that either have treatments or we have ongoing trials. So we have to fight to make a diagnosis. And not to mention the fact that we have guidelines now. This is from the National Kidney Foundation guidelines from just December of 24. You see here on the left, this box. These are specific recommendations for whom we ought to consider genetic testing. Do they have a family history? Anytime you're thinking about a biopsy, you need to add genetic testing data that will really enhance our ability to interpret that biopsy. CKD, unknown etiology, cysts. We have to think about adding on genetic testing. We went ahead and we do a renacite in this case, and boom, this was not PKD. This was not IFT140, UMOD. So this now we want to know broadly when we have CKD, knowing that I have a positive genetic test is very important prognostically. When you look at this particular trial of over 5,700 patients, CKD of any cause, having a positive genetic study, we know that they had a 72% higher risk of kidney failure. So going back to what do I have? Why? What will happen to me? And what are the treatment options? I can't answer these questions without doing everything I can today to make a diagnosis. And for my CKD unknown etiologies, which is probably upwards of 40% of the patients I see, I may have a yield, as high as 20%, if I go on and I do genetic testing. When you look across MUC1, UMOD, HNF1B, these are tough cases that go undiagnosed. The sediment is bland. They have minimal proteinuria. You see the different genes below here. HNF1B, we may have certain clues, hypomagnesemia, they get diabetes, gout at a young age, UMOD especially, at least 50% have gout before about 45 years old, but they don't have metabolic syndrome. So maybe we ought to think about doing genetic testing for those patients because these may account for upwards of 2% of people who are sitting on dialysis undiagnosed. So really, again, in this case, they want answers. I couldn't have given them the answer without employing genetic testing. So in the last couple of slides, I just wanted to include this. When you look at studies like the Irish Kidney Gene Project, positive family history, CKD, CK uncertain etiology, extrarenal features, they have broad genetic testing. Yields were about 50%. And look at MUC1, way up here. And MUC1 is not easy to diagnose with next generation sequencing. We have to go a little bit further. And look at UMOD. Two of the top six in this trial. So ADTKD is probably a much more significant part of everyone's practice. They just don't know it. Now, we have this gene problem. We have a disulfide bond problem. We have misfolding of this protein that is now, quote unquote, stuck in the endoplasmic reticulum, causing interstitial fibrosis. Now, when you look here to the right, you can see those clumps of red. You are seeing that red UMOD is now inside cells rather than here on the left, where you have a ribbon on the apical tubular membrane where it should be. When it's clumped there within cells, that's what turns on an inflammatory cascade and leads to that tubulointerstitial fibrosis. Now, I just highlight BRD 4780, Dr. Brecker's group, that now this drug looked to have some off-target toxicity. So unfortunately, this may not be the drug that we see in human trials soon, but this is to make the point that we have very bright people, many who are on this call, as I have read a lot of your literature, that you look here, the upper right, that green clumping of MUC1 within cells causing interstitial fibrosis with drug exposure below, you no longer see it. It has been redirected to lysozymes for degradation. So, and you may not see it too well here, but the top you see purple with CD45 inflammatory cells. The middle left here with drug exposure, animal studies, of course, you don't see the CD45 inflammation. The right upper, you see fibrosis. The middle one to the right, you don't see that fibrosis. So understand that in clinic, all of my colleagues please that the research bench is like right next door to us. It's very adjacent. We have to make a diagnosis and get people to these trials so that anyone who I see who has family history, early onset CKD unknown etiology, I order genetic testing. 3 to 4 weeks later, I can get an answer and I have access to a genetic counselor. So this is how we need to start to incorporate to fight to make that diagnosis. So I appreciate it. I hope I didn't go beyond my little part. I can't hear you, Sharon.
Sharon, I think you're muted.
I am. Thank you.
Good.
That was excellent, Andrew. Thank you so much. And we'll move now to Maggie.
Sounds good. Thank you. So it's nice to speak with everyone today. I'm a genetic counselor and have been with the laboratory Natera for 14 years, working in renal genetics for the past almost 6 years, which has been really exciting. And I work with a great team of genetic counselors who speak with patients every day about their test results. We also speak with clinicians to help clinically correlate and understand genetic test results. and have made a number of ADTKD diagnoses through our Renasight test. So today I'd like to just discuss the role of the genetic counselor, and after a positive test result and why genetic counseling matters in ADTKD. So we'll talk about how genetic counseling can help reduce diagnostic uncertainty, identify at-risk relatives, prevent unnecessary procedures, inform kidney donor decision-making, support reproductive autonomy and decision-making, address psychosocial burden, and how this bridges the molecular genetic testing and clinical nephrology. So genetic counseling really translates molecular findings into informed medical and personal decision-making, by translating information that can be complex and difficult to understand into patient-friendly language. Okay. So when we receive a test result, this can really help clarify the diagnosis. And during result discussion, what the genetic counselor does is review the specific gene variant identified. In this case, in a UMA diagnosis, for example, we would review the inheritance patterns, so autosomal dominant inheritance. And we would help correlate the genotype with the patient's phenotype. So help the patient understand the clinical features that can be expected with the condition diagnosed, including progressive CKD, the findings of bland urinary sediment, hyperuricemia, or gout that's often early onset, and understand that there can be variable age at onset, and so which can lead to intrafamilial variability. So not everybody in the same family, even with the same condition or genetic cause, can have the exact same symptoms or the exact same age at which they have kidney disease. So that's something that we would review. And in some cases, a patient may have testing before having symptoms, and we can discuss the limitations of genotype phenotype prediction, meaning what's the exact signs and symptoms that someone's going to develop based on a positive genetic test result. So to discuss what's known about that those genotype phenotype correlations, and in some diseases they're very consistent and predictable, and in others there's much more variability. I think a really important part of genetic counseling that is something we have training in and devote our time to is helping patients process the emotional impact. I think as we heard earlier today through some of our patients' stories, is the diagnostic odyssey, the length of time at which many families, particularly in ADTKD, how long they go without a diagnosis. And this can be years or decades, right? Where there's and also awareness that there's a disease in the family history. There's an awareness that this individual has a kidney disease, but, all these years of not knowing what the cause is. So there can be a really profound emotional impact of just providing a diagnosis and giving a name to the condition. And, many families report these years or decades without explanation, having undergone multiple biopsies or misdiagnoses, have uncertainty around, whether there's something they did to cause this, self-blame for disease transmission to children, these sorts of things. So the genetic counselor really can help with validating emotional reactions, reframing the diagnosis, as an actionable finding, address guilt surrounding the inheritance, and facilitate family communication. So it's, I think, important for us to recognize that relief and grief can coexist at the time of diagnosis and help work through some of those feelings. So when we talk with patients about the inheritance and risk to family members, we would discuss autosomal dominant transmission and the 50% risk to first-degree relatives. We would explain that both males and females are equally at risk and can equally be affected with an autosomal dominant condition. And likewise, each pregnancy would carry an independent 50% risk to inherit a genetic alteration for an ADTKD gene, such as UMAD. So we would review specifically by taking a detailed family history, who in the family is at risk, and what the clinical screening recommendations would be for those individuals if they haven't had genetic testing. But discuss how identifying at-risk relatives enables, early nephrology surveillance, can help avoid unnecessary diagnostic procedures, and can really help inform donor eligibility when it comes time to consider a related family member for kidney donor to be a kidney donor. So cascade testing is the phrase that we use in genetics for testing other family members once a diagnosis, a molecular genetic diagnosis is identified in an individual. And this really is key because a negative genetic test result isn't as meaningful, unless the affected individual and the family or affected family members have a known molecular genetic diagnosis. So once we have that, we can then test specifically for that genetic variant in children, siblings, parents, and extended relatives, aunts, uncles, cousins. All family members who are at risk and are interested in testing could be tested for that specific variant. Most laboratories offer single site testing, which can also reduce the cost in some cases of the genetic test. And so the discussion points that we would review in cascade testing would be, the different issues with testing someone who's symptomatic versus asymptomatic. The risks of testing minors, generally, we don't offer genetic testing to minors unless there's a medically actionable, meaning a specific treatment that would be available to that individual. Typically, that's reserved for adults. And the living kidney donor considerations, and also discuss in genetic counseling, we always, address things related to insurance and discrimination protections. And so things like, perhaps establishing life insurance prior to having genetic testing as an option, and just understanding what the protections are that were afforded through the GINA Act in terms of prevention of discrimination in the workplace and in healthcare and health insurance. And also what is and isn't specifically protected under that legislation. Reproductive counseling can be applicable for individuals of reproductive age or even those who are worried about their grandchildren and so forth, right? Their children's children. So family planning considerations. We would review, of course, the 50% risk of recurrence in each pregnancy, and we can discuss the various options. So I heard it mentioned earlier today that there's not prenatal testing for these conditions for ADTKD. That's not specifically the case and again, this is where it's key to have that genetic diagnosis. Once we have a genetic diagnosis in an individual, we can perform prenatal testing during pregnancy through either chorionic villus sampling or amniocentesis to test for that specific mutation that's present in the parent. So that is something that's available, is routinely offered, in the prenatal space. And so a patient would be referred generally, during pregnancy to a maternal fetal medicine specialist and perhaps likely also have genetic counseling to help coordinate that sort of testing that's available during pregnancy. So the various options that someone who is at risk of passing on a dominant condition, right? The things that are discussed would be natural conception and perhaps postnatal testing or testing when an individual is an adult. And we talked about prenatal diagnosis. Another option for individuals is pre-implantation genetic testing for monogenetic disease, also known as PGTM, which is for couples who are can undergo in vitro fertilization, and embryos that are created through that process can be biopsied, and a custom assay can be designed to test for the specific mutation in the parent in the embryos. And then the idea is that only embryos that are unaffected and do not inherit that mutation, right, are transferred into the mom for conception. So that is a growing area, and there's more utilization of that over time. Our laboratory also offers that sort of testing as well. Use of donor gametes, so use of sperm donor or egg donor is also an option for couples who wish to prevent passage of an autosomal dominant condition to children or adoption. So I think it's important to recognize and just always remind everyone that genetic counseling is non-directive. We discuss options, we provide support and informed, values-based decision making. So we work with a couple and families to understand what their individual values are, what their desires are, and tailor our counseling to those. Another important part of genetic counseling is enabling family communication, so supporting disclosure within families. And so we can often provide a family letter that explains the diagnosis, the inheritance pattern, and testing availability, because the doctor that I go to is probably not the doctor perhaps that my sister goes to, or families live all over the country and are separated. So helping provides just a physical piece of information that describes what the genetic diagnosis is, what the mutation is, what the testing is that could be done for an at-risk family member, I think can be very useful. And we can help empower family members with guidance on how to approach conversations with family members, provide resources to their relatives, and also help patients navigate issues related to estranged relatives, general communication, generational communication differences, and cultural considerations. Practically, genetic counselors really help make testing available by assisting with ordering testing, ordering familial variant testing. We often end up seeing relatives of patients we've counseled. We can help coordinate getting kits delivered to at-risk family members, or communicating with someone else's nephrologist to help with clinic-based testing, interpretation of those follow-up test results. And we provide documentation of our counseling back to the nephrologist in the form of a letter, in order to make sure that there's that, continuity of care. So we really do act as a bridge between the laboratory, the nephrologist, and other medical providers, and as other family members. I think another important thing that genetic counselors make sure to focus on is connecting patients to community resources and support. So we provide referrals to the Rare Kidney Disease Foundation and other kidney disease advocacy organizations, research registries, clinical trials when applicable, and we provide reputable web-based resources. In addition, if there's an individual who is suspected of having something like ADTKD, but perhaps has a negative genetic test, but wasn't tested for the MUC1 gene, for example, that's not currently available really on any commercial panel in the US at this point, referring them to a research study to have that sort of testing. So that's something that we help with as well. So that completes my summary of genetic counseling services and the description, and I'm happy to answer any questions.
Thank you so much, Maggie. We'll hold all questions until Dr. Vuppali goes, and then we'll open it up. So let me turn it over to you, Dr. Vuppali.
Okay, let me share my. Okay. See, I think I'm muted. Okay. I hope everybody can listen to me.
Yes, we can hear you fine.
Okay, so anyway, my name is Madhavilatha. I am a nephrologist in Houston area for the past 15 years. So I will tell my little bit of journey about why I believe genetic testing is very important and how we can do in this 15 minutes of the patient encounter, regular daily basis, how we can work in the clinic. So, this is a simple thing. I think everybody is, talking about the same thing. Why is genetic testing important? Why we want to do it. So I think there are a lot of, etiology that we don't know. Like if you actually know most of the ESRD patients, at least 20% of the patients actually are still no etiology. When we write this diagnosis on the form, sometimes we just say hypertension because we don't know the diagnosis actually, because never been seen any nephrologist, never had any workup done. So that's one reason that we need a genetic testing. So, and I'm actually doing in my dialysis patients also. And also, some of the diseases are runs in the family. So it's very important for them to have the genetic testing done, because when they get transplant, right, it also kind of affects it on the transplant. They know what kind of genetic testing, and especially if the family members wants to donate, especially with the polycystic kidney disease, they cannot really donate from the family. So it's very important to have that genetic testing to be done. And also people who are young at the, when they start in dialysis. So these are the few reasons. And if you go, this is the broad thing why we need to have a genetic testing done. As I think everyone mentioned, even Maggie also mentioned, family planning is very important when you're doing getting your, family, going about the genetic counseling, all those things, hereditary diseases, familial diseases, cystic diseases, young age. People who are diabetic, we all know that diabetes can cause kidney disease, but you'll be surprised people who are diabetes may have a different diagnosis, a different genetic disease that can cause kidney disease along with the diabetes. And there are so many other deficiencies because of the fact that there are different treatments. Not every kidney disease has the same treatment. We have a blanket treatment at the same time. People who has different genetic diseases has different strategies as well. So I'll tell a little bit of my journey when I started. It started in my fellowship back in Louisiana, where we used to see a lot of focal segmental FSGS patients because the population there is more African American. And at that point, we didn't have any genetic testing at that point. We just used to, do the biopsies if possible. If they're already end of the diagnosis, end of the, spectrum of the kidney disease, we may not even able to do that. So that's when I, found out and read about this APO1, gene that has been very, very notorious in African American. And, there was some trial just started and they're still going on, this amplitude trial. That's when I started really doing, research to see what I can do. When I started my practice in 2012 in Houston area. So I pretty much called every lab to see where they can do this testing. And at that point, it wasn't available until later, really about almost 5-6 years ago, the Natera rep came to my office and say, hey, you want to do genetic testing? I'm like, yes, this is what I've been really waiting to get that. So since that time, I've been doing a lot of tests from the Natera. So at that time, my focus was basically doing more for APOL, African Americans. So really doing that. So when I did that, this is my, basically had the results. If you see that, I have a pretty big range, a big percentage of APO1. At the same time, there are some other things also. If you look into that, that's when I started, it's not just the APO1. There's a lot more than APO1 that I found out that I want to really, look a little bit more, broader terms, not just the one area that I'm looking into that. So that's when I went to more, when I did a little bit more of that. This is my office people, results. If you look at that, it's still APO1 is my big one. But if you look at the other one, there are a lot of other things as well. PKD, it is, I think everybody, familiar, 20% of the population in my area has it. And if you see a lot of other genes that really don't see that, TTR is one of them, which is, I'm also, kind of focused on that because it is involves a systemic disease, heart, kidneys, nerves, a lot of things. So that's when I, started doing it. It's not instead of just started with APO1, but went on to having more diseases that I wanted to do that. These are the few examples that I do want to, give from my office. So this is a young patient, one of my nurses where I work at the hospital. She came out to me saying that I have this hematuria. It's not like she's not urinating blood, but every time they do a blood test, they see the blood, right? So of course she's been urology many times. They did a cystoscopy, multiple things. Everybody said, no problem. It's just a small thing. Don't worry about it. And multiple times she was treated as a UTI as well. So she came to me and said, and I asked her, she has no family history. She's from Romanian. She doesn't really have any family history that she knows of any kidney disease. So I did the test and of course it came back positive as output. So it's very important now that she needs to go back and talk to our family members because sometimes it's so subtle things that we really don't know. So it's very important. So she was very happy that at least she has a diagnosis now that she can work on that. And she actually went on to trying for some clinical trials for the outputs as well. And she went and had her hearing test done. And surprisingly, she does have a mild hearing loss, which she did not know about it. So it's really, fascinating to see those things. The other one, this is the patient came from India, already has a diagnosis of advanced kidney disease, had a stroke because of the hypertension, and his renal ultrasound definitely showed big cysts, multiple cysts in the kidney, consistent with the polycystic kidney disease. Then people do argue, like, why do you need a genetic testing now, right? You have the diagnosis from the imaging, you have everything. But he never had any family history that he knows from India also. You have to realize some of the developing countries, they may not have any, family history because they've never been to any doctors. So it's very important. Other important thing is that why the genetic testing needed, because he's having a baby and he's all very worried about it. So we did the test and he has a PKD1, which he had liver and kidney disease. So other unfortunate surprise thing is baby, after my genetic testing, they went and actually had talked to the pediatrician, neonatologist, and they did imaging, and the baby already had a cyst. So it's unfortunate, but at least at the same time, they came to know, it's overwhelming for them. He's on dialysis now, trying to get a, transplant, but it just helps the, family about the, kids when they're family planning and whatnot. So, and these are the same KDIGO guidelines. I think even Dr. Lazar also mentioned about it. When it came back, it mentioned the KDIGO also mentioned in the diagnosis of kidney disease, genetic testing is very important. And these are the recommendations they put, what the reasons that you would need to have a genetic testing done. So based on that, this is what I created for my office to easy for a regular visit. So every patient that comes to my office, we give this form. Right, we fill out the name and everything, and this is the questionnaire for the patient before the physician goes there, right? And it has I try to put as much layman terms as possible, basically telling that if the kidney disease started early, whether you had any kidney disease but not known any risk factors, and you had a cyst in the kidney or any protein, blood, had biopsy done, or I did put African American just because of the fact that I am, more biased on the APO1, that I'm looking for APO1. And surprisingly, some Hispanics also actually have APO1. That's why I put that in. Hypertension at early age. I never had any resistant hypertension, electrolyte abnormality, as Dr. Lazar mentioned. You have Gittelman-Liddle syndrome, have this hypokalemia, hypertension syndrome, sometimes not easily diagnosed clinically, but I actually have few patients for that too. So this is the form that I give it to everybody. In the form, we just put like whether it was ordered or not. So this is what I do from my office, right? Patient checks in the front office. And my medical assistant, she rooms the patient, and she gives the forms to the patient. And me or one of my doctor goes in there. We review the chart and we talk to the patient as well. Sometimes if they have any questions, we just go and tell them why we think it's a genetic testing needed. And then MA at the end of the visit, MA my medical assistant collects the specimen. It's easy. We have I'm so glad Natera people gave me all the things, test kits in office. We just do the test over there. We put all the details and we FedEx it, and we're done with the visit. So it is possible within like 10 to 15 minutes of your visit. It's very easy. There is no obstacles in between. And then they go, and then when they come back, that's when we discuss about the results, which is going to take about 3 to 4 to 6 weeks, depending on that. So, and then it is also integrated to my EMR. So a lot of times, if the patient does not have appointment or they miss appointment, they can always look into the my chart, and they can look at the results, and they can always call me. I always tell them, do not get panicked, whether it's a positive or negative. Just talk to us before you get more problem or thinking about the genetic testing. So it's very easy in a regular office setup that you could do it. And this is when I did more, patients enroll, when I did that form and give it to everybody. We did more patients, of course. We did like 95 in 1 month and 73, we did a lot of tests. And then most of the, patient, actually 66% of the patient actually we did the Natera are met NCAF criteria. So some patients, they do want to just get it done, even they don't have any reason. They do, just for them, make to feel better that they don't have anything going on. So it's very easy to, get it done. Other one sense that I want to put, like negative testing. Negative testing doesn't mean anything. It still means a lot, because sometimes a lot of genes that we don't have any thing right now, but they may get into later. So negative doesn't mean anything. It will give you at least the reasons that we're looking for is probably not there. There may be something else there. And negative also gives a assurance for the patient that they're not worried about the disease that what they're working or expecting for that. And also it helps the kidney donor. At least negative test will tell you that you're okay to go ahead and donate the kidney for your family. It needs to be done. So, and it it helps for the decision about if there's genetic disease that we need to have any special clinical trial. So it's very easy to get it done. And this is other thing that I put in my slide before also. This is a template that I use in my office for every office patient. So the genetic testing is right there. So if I forget, it'll just give me another remembrance that, hey, I forgot the patient to have genetic testing done. So it's just easier. It gives me everything if I missed anything. It's just a thing that I practiced over time, so that I don't remember, I don't forget, and it's a very good patient practice. So I think, overall, I think genetic testing is a very routine tool that helps the patients to, diagnose and help for the family as well. Negative test still has a meaning of it. So, and I think there are a lot of genetic, counselors are helping if they have any questions. So it's very easy on a regular day-to-day office practice. So if you have any questions, please call me, and this is my email and phone number. Thank you so much for giving me the opportunity.
Thank you so much, Dr. Vuppali.
Thank you.
Why don't we, Lisa, let's see if we have questions from the audience.
Yes, couple of questions. First one, I believe, is from a patient. It says, I was lucky to get tested very early when Athena Diagnostics had developed early kidney testing in 2005, 2006 at Columbia University. I also met Tony and his growing team. Genetic testing seems obvious. Clinicians, please tell us why this doesn't happen. It seems so clear. What are the obstacles?
That's a really good question. Certainly I can tell you that during my training, I didn't learn just about anything about genetics. I was also an engineer in my first career, so my undergrad and then master's was really engineering, so it's not as if I had a lot of the biology, genetics undergrad. I hope the younger people than me are getting more general genetics, but somewhere around 2019 was where I felt, this is an area that I don't feel strong, and I started to see the articles in Clinical JASN, New England Journal, and recognizing this is suddenly a primetime issue in nephrology. So I still think that we have to educate ourselves. Luckily, companies like Natera are really out there trying to get people up to date and understanding the impact of doing genetic testing every day. And so I also think that we went from having almost no therapies and nothing new exciting to having like too many new things, So any given day I see someone and I'm still worried about hemoglobin A1C, blood pressure control, the LDL cholesterol, because, we think cardiovascular risk reduction first and foremost. But, I do a lot of intermittent fasting with people, and then I'm trying to enroll people in trials, and, how do you keep everything top of mind? So it's challenging out there, and we need to use our technology, our electronic health records, to try to identify people for whom automatically using, like what Dr. Vuppali just showed, using something like that electronically to trigger automatic genetic testing. Sadly, at times we have to leapfrog healthcare providers, to try to get people tested and provide the best care while we wait for them to kind of catch up. Mm-hmm.
Next question will be from Maggie. In the past, cost and limited people doing testing. Is there a national list of genetic counselors with experience?
Yes, this is a great question. So there is so to get to the how to find a genetic counselor, if you go to the National Society of Genetic Counselors, and I can type that in the chat in a little bit, there's a Find a Counselor tool that can help you locate a genetic counselor in your area. To get at the specifics of, are there genetic counselors that are specific to renal genetics? It's becoming more common, but there aren't necessarily any. That's not to say that a genetic counselor, though, the tenets of genetic counseling remain the same. A lot of what we do is helping to coordinate the testing, explain inheritance, those sorts of things. So we don't necessarily have to be a complete expert in kidney genetics to understand and help guide a patient with a particular test result. I will mention that certain laboratories offer genetic counseling services. So, for example, Natera, which is my employer, offers pre and post test complementary genetic counseling services to patients. And then genetic testing, it's a myth that genetic testing is not affordable. The large majority of patients that have our Renasight testing pay $0 out of pocket. It's generally covered by insurance, covered by Medicare and so forth. So, and even those that do pay out of pocket, it's generally a very small amount. And we do have compassionate, and most laboratories offer this as well, compassionate pricing, so that if someone's able to provide some financial statement records and things, that testing may be offered on a sliding scale as low as $0. So that's something to be aware of as well.
Thank you very much.
Is that it, Lisa?
Yes, I think that's all we have time for.
Okay. Yes, I think that's probably good to move on to the next session. Thank you so much for a
Thank you.
very
Thank you.
informative panel.
Thank you.
I'm going to type that Find a Counselor into the chat. I hope that will show for everybody. Okay.
And we will share that also when we do our written Q&As and share with the audience after the. All right.